Good evening, friends. I am Dr. Anil Kumar Virmani, consultant physician and cardiodiabetologist from Jamshedpur, Jharkhand, today at the Right Doctors platform. The question that has been posed to me, how does sitagliptin fare vis-a-vis other gliptins? Now you see there are a number of gliptins we have in the market today, starting right from sitagliptin, linagliptin, vildagliptin, saxagliptin, teneligliptin, evogliptin, alogliptin. And if you look at the efficacy wise, whether it be the reduction in the fasting postprandial or A1C, the efficacy and safety is almost similar. There are minor differences as far as the safety is concerned, but the efficacy wise, there is no difference between any of the DPP4 inhibitors. In patients who have established atherosclerotic cardiovascular disease or high risk factors, then obviously the first choice is a GLP-1 receptor agonist, or if not affordable or not available, then an SGLT2 inhibitor. A second line, of course, along with metformin. A second line drug or third line drug, I would say, would be a DPP4 inhibitor, especially sitagliptin or linagliptin, because we have only these two gliptins which have cardiovascular outcome trials. The sitagliptin in the TCOS trial was cardio safe, and linagliptin indirectly in the Carolina trial, where it was compared with glimepiride, was also cardio safe. So we can use either one of these two in patients with established atherosclerotic cardiovascular disease. Now, it is managing diabetes in the elderly or in the geriatric population is indeed a great challenge, because these patients are often frail, they have cognitive decline in function, and they have basically polypharmacy. They are unable to remember and take the medicines properly. So it is better to give them a medicine which does not cause hypoglycemia, which is very safe. And this is one drug, DPP4 inhibitor, which can be ideally used in the geriatric population. In fact, during the COVID era, when we were not seeing patients physically, we always said that if you want to write one anti-diabetic drug blindly, that's a DPP4 inhibitor, because it is the safest drug available right today. Yeah, they are definitely a low risk of hypoglycemia, cardio safe, especially sitagliptin and linagliptin in the elderly. In the elderly, try to avoid teneligliptin, because these drugs may cause prolonged QT interval, and in patients with in the elderly patients, there's often polypharmacy, and there may be drugs which can lead to prolongation of QT interval and fatal cardiac arrhythmias. So the safest drugs in elderly would be either sitagliptin or linagliptin, and especially linagliptin if the renal function is impaired. Now, which patient profile would I choose in DPP4 inhibitor? Obviously, where the risk of hypoglycemia is high, whether their patients are having cardiovascular risk. Now, these are the patients who, after an SGLT2 inhibitor, I would prefer to choose a DPP4 inhibitor. In my clinical practice, I often see patients for whom the desired A1C reduction is basically more than 1.5, and then we have to use a combination therapy. And I think the best combination therapy would be a combination of an SGLT2 inhibitor, a DPP4 inhibitor, and a metformin. And in fact, in all my cases, I'm using these three combination, and today it is available as a single pill combination. So it is beneficial because it reduces the pill burden, it increases the adherence and compliance of the patient, and we are getting the desired A1C reduction along with all the pleiotropic effects. The one of the best combinations is, of course, SGLT2 inhibitors along with DPP4 inhibitors. When we see SGLT2 inhibitors, it has got a lot of pleiotropic effects. It does not cause hypoglycemia, and it has a positive cardiovascular benefit, cardiorenal benefit, in fact. On the other hand, DPP4 inhibitors are also safe drugs. They do not cause hypoglycemia, and they are cardio safe and renal safe also. Now, one of the most important things of the combination is that SGLT2 inhibitors often increase glucagon, decrease insulin, and increase the endogenous glucose production. And the DPP4 inhibitors just do the reverse. They decrease glucagon, increase insulin, and decrease endogenous glucose production. And hence, this is a wonderful combination. Both sitagliptin and linagliptin, as I said, are cardio safe. So, in fact, I would like to say that both are basically cardiogliptins, and we can use either one of them. But definitely, sitagliptin was the first one, which was in the TCOS trial proved to be cardio safe. And linagliptin would be preferable in those patients who are having an impaired renal. Now, as an add-on, when you are trying to maintain the blood sugar or A1C reduction, again, as I said, it all depends. You can use any gliptin because efficacy-wise, all are the same. But if the patient is a high cardiovascular risk case or renal or having renal impairment, then I would prefer to use either sitagliptin. I don't think sitagliptin should be prescribed twice daily. It's a dosage to be given 100 milligram once daily, and that is the right dose.
Insights from the world's best medical minds. You are watching therightdoctors.com.